Welcome to the Mountain West AETC Project Echo. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
I'd like to go to the didactic talk. Christine, thank you so much for doing this. This is a topic that comes up a lot in my clinic and I think comes up for everyone, so I will turn it over to you.
And I thought at first that we'd just talk a little bit about initial antidepressant selection real quickly. This comes straight from the American Psychiatric Association practice guidelines for the treatment of patients with major depression. You can get that right off the internet, and it's about a 90-page monograph, so go to some executive summary at the beginning is probably easier. But anyways, you really have to think about anticipated side effects and safety tolerability for the patient. That's number one concern, as well as the pharmacological properties of the medication and what other medications the patient is on. So other drug interactions, particularly when you have patients with HIV, Stribild, ritonavir, things like that that are strong CY3A4 inhibitors, because that will usually or oftentimes cause very high levels of antidepressants, and you have to work slowly in getting the patient to a tolerable blood level. Other factors include getting a good history of prior medication responses in the past and patient preference. Sometimes, we ask about family history and what family members were actually responded to. Sometimes you can get hints, for example, is this actually a bipolar depression, which would have a much different treatment. And then, of course, cost and what insurance will cover is always a major issue these days, because adherence is always a problem, and of course cost would be a major barrier to adherence. But for most patients, we usually start with an SSRI, or else mirtazapine, bupropion, or an SNRI. Remission is defined as greater than 3 weeks of the absence of both sad mood, reduced interest, and no more than 3 remaining symptoms of major depressive episode, like insomnia or poor self-esteem, anhedonia, things like that. But you really need treatment of at least 4 to 8 weeks at a therapeutic dose before you can conclude that someone is partially responsive or unresponsive. And probably only about 40% of people go into complete remission with their monotherapy of an antidepressant. And there's another 30 or 40% that have only incomplete remission. And then a small percentage of people who have no effect at all from the antidepressant. We want to see at least substantial remission by the end of 4 to 8 weeks. And if not, we start considering other options and what else to do. So another definition here is the difference between treatment-resistant depression and treatment-refractory depression. And treatment-resistant depression is considered to be a major depressive episode that does not respond to at least 2 trials of antidepressant monotherapy, while treatment refractory is an episode that doesn't respond to numerous sequential treatment regimens. And that's the type of treatment refractory episodes that we refer for ECT, electroconvulsive therapy, or much more complicated medical regimens. So I want to remind people that even mild residual symptoms are associated with pretty significant psychosocial disability compared with an asymptomatic remission. These people oftentimes will relapse 3 times faster to a major depressive episode. They have a more chronic future course. And apparently the presence of mild residual symptoms is even stronger predictor of a subsequent return to a major depressive episode than a prior history of multiple episodes of major depression. So if you're not seeing at least mild to moderate improvement in symptoms after 4 to 8 weeks, well, the first thing we do is reappraise the diagnosis. So we want to rule out medical causes such as thyroid disorders, personality disorders that may be comorbid. Is there a substance-induced disorder or a bipolar diagnosis? Those are the major things we're concerned about. We also need to assess side effects, review those complicating co-occurring conditions, and psychosocial factors. For example, here at Harborview, we get patients who are chronically homeless. They're depressed. Is it because of their chronic homelessness? Are they going to be less depressed once they find housing? You know, is this antidepressant going to work if they continue to be homeless? Those are you know, issues that we deal with and wonder about, because those psychosocial factors are very significant. We also, of course, have to evaluate treatment adherence, because maybe 40% of people who are put on antidepressants for major depression actually have good adherence to their antidepressants. Oftentimes they'll skip doses or they'll stop entirely. Oftentimes it's the amotivational or anhedonic and low energy portions of the depression that interfere with their adherence. I always ask about adherence. You can hear, I mean, no matter, even if you've asked, 6, 8, 10 times, you know, the one time you don't ask, they're going to reveal that, oh yeah, they stopped that a month ago, you know. It seems to happen always that way. So there's also non-specific care management that we do, so educating the patient about depression, about suicide, about other treatment options, about sleep hygiene, because oftentimes sleep, you know, obstructive sleep apnea or poor sleep hygiene can certainly interfere with patients' resolution of their depressive symptoms. We always also review with the serial PHQ-9s, remembering that less than 5 is actually in remission, while greater than 20 is a severe depression. Of course, review adherence, like I just discussed, and talk about side effects, because, you know, they might say, oh yeah, I skip my SSRI, you know, 5 out of 7 days of the week because it interferes with my libido. I mean, these are things that you're going to hear patients say, and you're not going to know unless you actually ask them. And assessing suicidality. Right now, that's a real big push right now in primary care, to assess suicidality and actually set up a crisis plan. If you should become suicidal, do you know what to do? Who would you contact? Can you contact this crisis line number? Can you contact your case manager, the clinic, etc., and review that periodically with patients to remind them. I always like to ask for suicidality is, so if you're feeling suicidal, what stops you? What kind of things would you miss or would you regret should you kill yourself? And that helps remind them what they would be living for. And that's very helpful. If there's an inadequate response, the first thing we're going to do is optimize the dose, as long as the side effects are tolerable and the upper limit of the medication hasn't been reached. The other thing you can do is augment the antidepressant with psychotherapy. If you're lucky enough to have access to a psychotherapist, and I know that's hard for patients sometimes, especially in rural areas. And then, of course, changing to another antidepressant, another monotherapy, a second of a different antidepressant. And then, of course, you can augment with other agents. Finally, if nothing else works, you're going to do, and it's actually treatment refractory, then you could refer for electroconvulsive therapy, but oftentimes it's not performed everywhere. There's only 2 or 3 hospitals in the Seattle area, for example, who will do ECT. So, and insurance, it's actually easier to get insurance to authorize it than you would think. But you do have to document what failures they were, how long were the patient on the antidepressants, what dose was the antidepressant on, things like that. When you switch to another antidepressant, it's, I think a cross taper is the best way to do it, especially if you have a patient on an SSRI or an SNRI. So what you would do, for example, if you wanted to switch someone from Paxil to mirtazapine, say, or bupropion, what you would do is cut the Paxil dose in half, wait a couple of weeks, you would add the mirtazapine or bupropion at maybe half the therapeutic dose, and then after a week, increase the mirtazapine or bupropion further, and maybe you want to cut that Paxil into 1/4 of a dose, for example. So if you had them at 40 milligrams of Paxil, they weren't responding, cut down to 20 when you add the mirtazapine or the bupropion, Then a week later, you can cut down to 10 as you go up to the mirtazapine or bupropion. The reason for that is that you run into serotonin discontinuation syndrome, which is particularly hard on the patients. All of a sudden, they just seem to crump, and and you think it's a failure of the mirtazapine or the bupropion, but actually it might simply be the discontinuation syndrome that's complicating the picture. The exception with that is fluoxetine, which is so long-acting you really don't need to cross-taper fluoxetine because it will be in the patient's blood for 2 weeks, 4 weeks. On the second antidepressant trial, when you're switching to the new antidepressant, you want to try an antidepressant usually that it works with a different mechanism of action. So if you have the patient on an SSRI, and you might choose to go to either mirtazapine, bupropion, or an SNRI, which would be different actions. You'd probably have a better luck with that. As well as with augmentation. If you're going to augment with a second antidepressant, you choose that depending on the residual depressive symptoms. For example, is the patient having a lot of residual anxiety? Then you'd probably want to do mirtazapine rather than bupropion, which is more of a stimulant effect. Or, for example, another example would be if you have someone on mirtazapine and they're complaining of excessive sleep, they don't have any energy, well, then you'd probably want to add bupropion or something like that. Either switch from mirtazapine to bupropion or add bupropion. You ask about side effects, sexual dysfunction, insomnia. Are they having mood swings, anxiety, energy or appetite problems? And that will kind of guide you in your selection of the next antidepressant to try or to augment with. Other augmentation strategies besides another antidepressant with a different mechanism of action would be adding buspirone, which is a serotonin agonist, adding a mood stabilizer, such as lithium or lamotrigine. Those are the 2 most common mood stabilizers that we augment with. Adding an atypical antipsychotic, or adding triiodothyronine or cytomel, T3. And any of these different augmenting strategies, you're going to get about a 30% response rate when you try and augment. So 30% over the initial response rate that you get. So once people have been treated successfully with the antidepressant in the acute phase, they should continue with this agent for about 4 to 9 months. When they're tapering off after that, you do taper slowly. I take 2 weeks to 6 months if I have to taper some people off. The worst medications, well, we'll talk a little bit about serotonin discontinuation syndrome in the next slide, so let's wait on that. Some people you're not going to want to taper off after they're 4 to 8 weeks, and then you can go into the maintenance phase, and that's people with 3 or more episodes of major depression or patients with chronic depression. These people, who have risk factors for reoccurrence, including psychosocial stressors, ongoing residual symptoms, and family history of mood disorders, they should probably continue indefinitely on antidepressants. Okay, now let's talk about discontinuing antidepressants. Usually, we try and taper the augmenting agent first. So if the augmenting agent is cytomel or a second antidepressant, we would stop that one first and then continue on the original before tapering that down. But sometimes, if it's a psychotic depression or if you think it has a bipolar component to this major depression with mood swings, then you might want to go down on the antidepressant first before actually taping off that antipsychotic or lithium, for example. It all depends on the patient and their response, and you kind of have to follow them a little closely as you're going off of the antidepressants. Warn them about reoccurrent signs and what to do should their depression continue again or re-exacerbate. Some of the worst discontinuation syndromes occur with venlafaxine, so the SNRIs, venlafaxine specifically, which is almost why I usually don't use venlafaxine unless the patient has chronic pain or unless the patient has failed 2 other antidepressant trials, because I know once they get on venlafaxine, it is going to be chronic treatment. Usually it's very hard to get them off of this. But I have had success with both things like paroxetine and venlafaxine is if sometimes I will, when I'm tapering them off, when I get them down to the very smallest amount and decide to stop it, I add Prozac for a few weeks. And that's because of its very long duration. And that way their blood level will continue to decrease very, very slowly. Sometimes I have them take also when they're down at the lowest dose of their SSRI or SNRI. I'll tell them to take it every other day, for example, and then every third day. We can get them off most of the time, but they are at risk, of course, of relapsing. Other discontinuation syndromes include tricyclic abrupt discontinuation, where you'll get a cholinergic rebound that can be quite distressing for the patient. Of course, when you discontinue anticonvulsant, you might have seizure, you might have mania. With an antipsychotic abrupt discontinuation, if it's a first-generation antipsychotic such as Haldol, Prolixin, you can get withdrawal dyskinesia, so you can stop the antipsychotic and they will all of a sudden start having symptoms of tardive dyskinesia, which will gradually attenuate over a week's period, and we don't usually worry about that. Of course, with atypical antipsychotics, when you discontinue those, you weight loss and insomnia, and then of course manic or psychotic relapse is possible. All my patients who are on atypicals who start losing weight pretty rapidly, I always am convinced it's due to stopping their antipsychotic medication. They really have to convince me that they're taking it if that occurs. That or they have diabetes. Let's see, we have some new antidepressants coming down the pipeline. Agomelatine sounds really interesting. It actually is a totally different mechanism of action. It's a melatonin receptor agonist, and it's got a very good side effect profile, but it's only available in Europe right now. So we have to wait. There's vilazodone that's been out for a while now. I don't know if people have had a chance to. It's a serotonin modulator. It's similar to nifazodone. Vortioxetine is also a serotonin modulator, and it stimulates serotonin release as well. Then there's levomilnacipran, which is very similar to milnacipran. And just so you know, underneath that, I've got the serotonin norepinephrine ratios of the SNRIs. So venlafaxine being the most serotonergic, duloxetine, desvenlafaxine, milnacipran, and levomilnacipran, which is actually 1 to 2, which has the highest norepinephrine adrenergic, I should say, effects.